answer to before you put someone in mechanical ventilation. And we'll go over them one by one. Why I'm putting this patient in mechanical ventilation? And we went over this before, right? So if my patient qualifies for non-invasive, I'll do non-invasive. If they qualify for high flow, I'll do high flow before I put them on this horrible machine. Mechanical ventilation is not a good thing. Anyone of you been in mechanical ventilation before? Inshallah, but it's a very bad experience. It's a very bad experience. Everyone would remember it for the rest of his or her life. Actually, some people, there's a guy who spent like 6 months on mechanic because he had a Guillain-Barré and he was paralyzed and he had to be in there. He wrote a book about it and he explained how bad and how very American guy, very bad experience, and how people stand next to the bed and talk about him and talk about the prognosis and talk about the disease, and he was just listening. He cannot do anything. It was a very interesting book. So what's the indication? Why I'm doing it? Question number 2, what mode should I select? What mode you should select?
More that you
That's the answer. The mode you're comfortable with. The mode you know. Don't worry about anything else. Just turn blind eye about it. Setting. What's my setting for this particular patient? I know a range. I know FIP should be 60 to 100. Rate should be 8 to 20. Blah blah blah. But this patient, this asthma patient, this ARDS patient, this whatever patient, this patient who just coded, what rate should I do? So again, this is for you as a clinician to make the call. Okay. What's my goals? And goals here, look at the not goals now, goals later on, right? So what I meant by this question is this patient is going to benefit from the ventilator or just keep the family quiet or satisfy myself because I did something there. Someone who's terminal, dying, why I put them in the ventilator, right? It's just making the last days of his life miserable. Maybe non-invasive is not enough for him. Maybe just a high flow nasal cannula is enough for him. Maybe I can talk to the family and say this patient is dying and there's nothing, his cancer is everywhere. There's no point in putting them in a ventilator. So what's my goals there, right? So this is there someone who's going to be in the ventilator for a long time and should be thinking about a custom like the brainstem stroke. It's not going to wake up this guy probably, right? So should I prepare the family? Tell, hey, we're going to put them in a ventilator now, but there's a chance we'll put a custom in this patient. So prepare them. Communication is very important in our job as a physician, especially in the ICU. Okay. And again, what we tell the strategy is goes with the setting here. Should extend the expiratory arm. So this is because it's COPD, CO2 is high there. Should I do higher rate? Should I give small tidal volume because this is ARDS? So this is what I meant by ventilator strategy. When I should use the PEEP, is 5 PEEP is enough or should I optimize the PEEP for this patient? So decision about what PEEP you use. What are the potential complications in this patient? What are complications we can get from it? I did not write them here, but we can go over them. What complications you have with when you put someone in mechanical ventilation? So ventilator associated pneumonia. When do you start thinking about it?
After 48.
After 48 hours. So my patient starts spiking fever, secretions are worse, X-ray looks uglier than before. Probably there's something cooking there. Okay. What else?
prolonged stay in ICU.
Bowel trauma, volume trauma, all kind of trauma to the lung. Okay.
ميتابوليك اللي هي الريسبيراتوري الرونج سيتنج يعني الداخله في اسيدوسس الداخله في الكالوسس.
Okay, this is okay.
Prolonged stay in ICU.
Oxygen toxicity.
Oxygen toxicity.
Oxygen toxicity. Problems with the intubation itself. How about intubation itself? Difficult intubation, trauma here.
Yes.
How about medications we give? Right? How about critical care illness, right? If I put someone on a ventilator for 2 weeks, will he be able to breathe and move and do things related to the bedsore, to DVTs and PDs and all kind of things because your patient is not moving, is not active. So these are the things which you should think about when you put someone on a ventilator. And every day, You have someone in mechanical, make it rule in your practice. Every day you walk into the unit, your ICU, and you have someone in mechanical ventilation, you ask yourself why he is on mechanical ventilation. What can I do to wean him off, take the ventilator away? Don't just say, oh, okay, 40% and go to the next patient. So your question is, okay, what's the problem here? Why he's still in there? Is his disease still worse? Is he fluid overloaded? Is he weak? Am I doing a good job with the nutrition? Does he need more physiotherapy? Do we need to change the antibiotic because my antibiotic is not working? Infection is just getting worse. Is his cardiac function is okay? His ejection fraction is good? Does he have any cardiac ischemia? So all these questions comes to your head. Why I'm not able to wean off this patient? It's very important. Otherwise, your patient will be there forever if you just do the vitals and walk away. Okay, so these two messages again you should remember. All machines provide similar, if not identical options, though the names are different. We saw it in the last screen, last two slides, right? Same mode of ventilation given like 4 names or 5 names. Each manufacturer or ventilator company will give its own name, so they will be unique, they will be different, they will be whatever, right? But it's the same thing. We're doing this, we're giving volume in all these ventilators, right? And the other one, that's the most important, know your ventilators and familiarize yourself with what you have in your unit. Don't worry about another ventilator called Bennett in the other part. You have Hamilton, look at the Hamilton, read about it, talk about the company, people know your machine, what you can do, what you can, as I said the other day, is like you buying a new cell phone or a new computer and you spend a lot of time, how I copy the names, how I do this, how I do that. Learn about your machine. It's familiar, make yourself familiar with the machine. It's very important. Okay, so modes of ventilation. I don't know why the title is not showing up there. But, so we have a continuous mandatory ventilation. What does it mean? When we say continuous mandatory,
purely dependent.
okay, that is part of the answer, but there's something missing here. So the continuous mandatory ventilation is a must. Huh?
The ventilator will continue despite the patient is taking breathing now.
So the machine or the ventilator will guarantee whatever you set on the machine. I want 400 of tidal volume and I want my patient to breathe 10 times a minute. The machine will guarantee that for you. Okay. That's the situation 40 years ago. Now they still call it CMV, but they added AC, assisted control. There's no pure CMV here. If you see it in the OR, because in the OR people get paralyzed and the anesthetist will do everything, right? But in the unit, you don't see CMV, pure CMV anymore. You see CMV with AC or AP either, AC, assisted and controlled. So as we said earlier, the control is CMV and you'll see after that AC, right? So the assisted is, if the patient breathes, the machine will give him a full tidal volume. If the patient does not breathe, forget to breathe, sedated, paralyzed, the machine will guarantee the number of breath you, or the rate you asked for. And this is what they call mandatory. And this is your favorite one, right? It's science. That's what we know. I'm just kidding.
Yes, our favorite.
So what's the difference between CMV and CMV? It's IMV and CMV.
لو المريض بياخذ يعطي وعنده مانداتوري ضروري يعطي.
Okay.
But synchronized. في
The other one is synchronized too. Why do you think the first one is not synchronized? It's synchronized. If the patient triggers the machine, the first one, the machine will give the full breath. So it's synchronized. But what's the difference between both?
was initiated والبريثنج.
No, it's not the same. We having 2 titles there. If it's the same, why I have to repeat myself?
الأول أعتقد ما يخليش المريض ياخذ هو يتحكم.
The first one is not dependent on the patient taking
If he takes,
the second is according to the patient. For example, you want to take the breath, we give him.
Okay, let me rephrase it. Which one is better, this one or this one?
according to the patient.
According to the patient.
Okay, for you, God forbid, inshallah لا يعني, بس لو حطوك على mechanical ventilation and they give you the choice, say you want CMV or SIMV, which one you will pick?
يعني بنتريح بالكامل ناخذ السي ام في.
Thank you. Why?
لان متريح يعني ما هو اللي واخذ الكنترول.
ما نقعدش فايتنج معاه، ما نقعدش فايتنج
ما
معاه.
نقولش ايوه.
What makes you fight with this SIMV?
أن مرات إني ناخذ نفس وفي نفس الوقت الجهاز مثلا بيعطي في الاكسبيريشن فيز والعكس صحيح، يعني مرات نبي نعطي اكسبيريشن والجهاز يعطي فيه اكسبيريشن.
يحددها هل فيه
هذا السنكرونايز
يقدر ياخذ
معاك ولا لا؟
هيك اللي فاهمينه.
Yeah, أنا فاهم. And I want to know what you know so I can plan myself. So look at this graph. So this is time. So patient start. We'll talk about CMV. Patient, this is the peak. Patient start. Take a breath. Goes away. Exhale. Take a breath. Exhale. Okay. So this is the machine. Now, this is the peak line. You see. Now the patient wants to take a breath, right? Because he's just waking up and he feels like he want to take a breath. So he will trigger the machine. He will suck negative pressure, and the machine say, "Hey, he wants to breathe. Let's give him the." And you want them. This is a 400 tidal volume. The machine will give him a same identical breath, 400 tidal volume. So if he doesn't breathe, the machine will give him a breath. If he breathes, the machine will give him a breath. Both are 400. Both patients satisfied, and this is why you want to be in CMV. Is that clear here? Okay, let's look at the SIM. This is the pressure control, by the way. Look at the SMV, SIMV. Same thing. I want 400. I want 12 breaths. Okay. So patient is awake. The machine will give one. Again, machine. Right? Now, the patient woke up, right? And he wants to breathe. Machine, oh, you want to breathe? Okay, we'll give you breath. Again, we'll give you breath, right? Now, 30 seconds, the machine gives the machine, there's 12 breaths in the machine, right? The machine gives the 12 breath. Now we still have 30 seconds for the patient to breathe, right? Now the patient wants to breathe. The machine said, "That's not my business anymore. You're on your own. They told me to give 12 breaths. I'll give you 12 breaths. 12 breaths, you had them. But I want to breathe. Okay, try yourself." But this is what small volume.
Okay.
So what will happen here? You will be happy.
Different.
No.
You will be distressed, right? You say, you want to breathe and you suck in air against all these tubes, right? So this is the old version of SIMV.
دينا support يعني.
Now they started doing a pressure support, right? Say, okay, let's do SIMV with pressure support, right? But how much pressure support I would give you? Let me guess, maybe 10? 10, right? Okay, I'll give you 10. Now, same story with the pressure support here, 12 breaths. So we exhausted the 12 breaths, and you still have half a minute before the machine start giving the preset rate again. So it will give you, I'll give you 10. So the tidal volume went up to here. Okay? Still, I'm not getting a good tidal volume there. So what do? You come back and you go up on the pressure support. Probably he have a big lungs, big body, so he needs 15 of pressure support. I give him 15. Okay. So you see the difference? Clear?
بتعبك انت تبي تخدم وتزيد.
Right. So this needs a lot of work from you,
Yes.
from the nurse, from the RT, right? Comparing with the SIMV, doesn't need anything. So you see the difference between both? Don't get deceived by the name. Synchronized. Oh, everyone is happy because it's synchronized, so that means everyone would be happy there. This is not. This is synchronized more than the synchronized one. Clear? Questions? So this is the... Now? So this is the SIMV. Then the spontaneous ventilation or pressure support ventilation. Pressure support. What's the pressure support? When we say this patient in pressure support, when do we use the pressure support ventilation?
Patient taking spontaneous.
Okay.
وين مثلا؟
When we try to wean someone off the ventilator. ثلاثة ما بس يحكوا التانيين كلهم نايمين. مش واضح ولا مكسلين ولا ايش؟ شباب دهان والشباب دهان. شارك يا أخي. Alright, so when we use spontaneous, when we try to wean people, right? This is the most common use of pressure support ventilation. So how does the pressure support ventilation works?
نفس اللي حكيناه غادي.
Yeah, but here
النص اللي على اليمين.
النص اللي على اليمين. Very good. So the patient will trigger the machine, right? He can trigger whenever he wants, and the machine will help him to breathe. He can decide the depth of the breath, how much he wants to take a breath, right? You decide how much help by the amount of pressure you give to your patient. And I'll show you some graphs in a second. There's other modes, they're not our topic today, airway pressure release ventilation, adaptive supportive ventilation, there's a lot of them, but this is what we covered the first three today. Remember, CPAP is not a mode of ventilation. CPAP is not a mode of ventilation. Okay. So the pressure control, again, there's no title there.
بالك الكلر ولا شو.
Continuous mandatory ventilation. So commonly referred as assisted. Nowadays we don't say CMV, we say put the patient in AC or PC, right? Pressure controlled or volume controlled or AC. Okay. So as we said here, mandatory breaths and the triggered breaths, they are the same. So whatever the machine gives, whether the patient triggers or the machine triggers, will be the same tidal volume. Yes? Yes? You're not happy.
Me?
Yeah.
No.
Okay, good.
هون بريست الريسبيراتوري ريت في الاي سي
Yeah, we'll
حاطاني
see.
مثلا 12 البيشنت ياخذ
Okay. ياخذ شو؟
مثلا 5
Okay.
بدا ينش قصدي يعطيه 12 بس في كل 1
1 minute.
12 بس
12 guaranteed, not less than 12. But if he wants to breathe 25, the machine will give him a full breath of 25. هتعطي 12 هتساعد المريض في 13 ثانية الباقي whatever it is. Whenever he wants to breathe, the machine will say, hey, he wants to breathe, we'll give him a full tidal volume. That's what we said here. Okay. If you see here, so both are identical. The mandatory and the patient trigger will be identical. Identical means same tidal volume. Okay. So in this kind of setting, an AC or CMV AC, you set up the respiratory rate, you set up the breath type, I want to give volume, I want to give it pressure, you decide how much FiO2, you decide about the PEEP and the trigger sensitivity we discussed earlier. Okay? Any question? Okay. So in a volume, the clinician or you or the physician will decide about the tidal volume. And we said earlier how we decide about the tidal volume based on the disease and its cc or mil per kg, right? Stop me if you. In volume we decide about the flow. In the pressure we don't. In the volume controlled ventilation we say I want to flow 30, 40, 60 liters per minute, right? Okay, don't worry about this. I don't know why it's not working. Okay, just quickly, we'll add one thing in this curve. Remember we have a peak pressure here, this is a volume. We have a plateau pressure after we pause. We have a PEEP here. We know how to calculate the static and the dynamic compliance, right? I'm going to add something here. Drive-in pressure. Now everyone nowadays talking about the drive-in pressure. What's the drive-in pressure? there is a guy from Brazil called Amato. He's a big gun in the in ventilator business. He did a study, and he found the bigger the driving pressure, which is the difference between the plateau and the peak, this part here, the more harm you do to your patient. Means, he said if you ventilate someone with a driving pressure of 15 or lower, you're safe. If you do pressure more than 15, you're doing some alveolar damage. So maybe you'll hear about this, just keep it in mind if you want to read
15
about it.
the number.
The number is 15, yes. The cutoff is 15. And this is what we call driving pressure. So from this curve, you can learn a lot here. And remember, the area under the curve is the
Oxygenation.
no?
main
airway pressure, which helps your oxygenation by making this bigger, the area bigger and wider will improve your oxygenation, right? So for the pressure control, we set up the driving pressure, right? Or inspiratory pressure, or whatever you want to call it, right? We don't do volume, we do pressure. Here, the pressure would be, and I'm just going to draw it here so you remember it. So, if the patient starts time and pressure, time. This is the peak. Patient started breathing from here. There is 5 of PEEP in his lungs all the way. So the patient started breathing from here. I reached my peak. Patient will hold that breath in his lungs for whatever inspiratory time you decide for him. Exhale. So the pressure curve will be square all the time. Here, your peak inspiratory pressure equal your plateau pressure. So whatever PEEP you have, 5, and I say I want to add 20 of pressure. 20 plus 5, this is my plateau pressure. You don't have to do anything. Just look at the machine, PEEP is 5, I'm giving him driving pressure of, inspiratory pressure of 20, his plateau is 25, I'm safe. If you give him driving pressure of 35, you will make his plateau 40, right? Is 40 good?
No.
No. My aim is less than 30. That's the compliance is 60. Okay, which part? What are we saying? We want to keep the plateau pressure in my patient always less than خليه هو يجاوب. Less than 30. Okay, 25 is better than 30. 20 is better than 25. I agree with you. But just remember this 30. 30 or less. Higher than 30 will do some damage. Less than 30, less damage. So, what I'm saying is, in a pressure-controlled ventilation, you're given a pressure, right? You're not given volume. You have a control over the pressure, but you have no control over the volume. So I give a pressure of 20, and I start with PEEP. So the top of my graph, pressure graph here, represents my plateau pressure. I didn't have to do the pose like what we did earlier. We didn't have to do this. It could be just one square. So the pressure I decided, the inspiratory pressure, plus the PEEP is my plateau pressure. In other words, peak inspiratory pressure equal plateau pressure. They're both the same, right? If I go, my patient is CO2 is 120, and I want to ventilate him. I want to use a pressure control. So I say, okay, let me try with a higher pressure so I can wash out the CO2. This is what we tend to do, right? So I give him driving pressure of 40 or 30, and I'm giving him PEEP of 5. What would be his plateau pressure? You.
45.
The 35? خليه هو يا رجل. 35 plus the?
The big pressure.
No, plus the PEEP. Both are. So it's just simple equation, right? So always think about it when you do put someone in pressure control. Make sure your pressure should not be higher. The sum of your pressure, the PEEP and the driving inspiratory pressure you sit in your ventilator, should not be higher than 30. Is that clear?
Yes.
Okay. Okay. What will you say here? You set up the inspiratory time. You have no control over the tidal volume. We all agree here? You're given a pressure, you have no control over the tidal volume. Tidal volume depends on
driving
some mechanics, compliance. I give a pressure of 20 to this gentleman, he will have a tidal volume of 600. I give the same pressure to him, he will have a tidal volume of 400. I don't know, I just don't blown air. I don't know the amount. Yeah? And this is the message, if you remember this one will be good. Plateau pressure equals plateau pressure, and the peak airway pressure will equal inspiratory pressure plus P. And this is the square wave form I just told you about. This is from pressure controlled AC, assisted control. So this is what you will see on your pressure scale. Any questions so far? Okay. This is the SINV. We went over the SINV. Everyone knows how SINV works? Okay. So, if you remember this one, mandatory pressure and patient triggered pressure are different once you exhaust or you done with the preset rate. Yeah?
باش نختصرها بس ومش عارف هل هي صح ولا لا مش نثبت المعلومه يعني. تو السي ام في بس اي ام في المانداتوري هذا بروحه البريسيتنج تمام الديفرنت كلها في الاكسترا صح؟
صح.
سي ام في البيش المسؤول عن الانشيشن بس لكن هو اللي حيكمبليت الميكانيكال فنتيليشن هو اللي حيكمل هلا بالتايدل فوليوم والدنيا دي كلها. والسي اي ام في البيش المسؤول على التريجرنج وعلى كومبليت السايكل بالكامل ماليش علاقه الفنت بالاكسترا.
سبورت.
لو حطيت بريشر سبورت.
لا في الاس اي ام في if the patient triggers before the ventilator finishes the
لا الاكسترا
اي after
لا
الاكسترا بعد ما يخلص
هو
الفنتليتر البريسيت ريت البيشنت is in his own.
الا لو في بريشر سبورت.
ولا لو في بريشر سبورت اللي هو حيساعد بس does not guarantee the same time.
بينما تلاقي الجميع
لو كيف يتلاقى
تلاقي
الجميع؟
الجميع مثلا في التايم دع المانداتري في الاس اي ام في هذا وقت
It's extremely unlikely انهم يتلاقوا جميع لان if the patient triggers the machine will not trigger. يعني at the same time. لكن if the machine starts then the patient wants to take a breath again it can happen with the space of milliseconds. It can happen هذا في asynchrony. معناها في حاجة غلط. مثلا الماشين trying to give a tidal volume والمريض حتى هو عاوز يتنفس means maybe tidal volume is not enough. Maybe the pressure you're given is not enough.
Air hunger.
Maybe he's air hunger. Maybe he's in pain. Maybe he's so you have to think about other potential reasons.
يعني اقصد يعني مثلا هو هذا الوقت مدعى
Okay.
بالتايم
بالتايم.
المفروض تو ياخذ مانداتري.
Okay.
المريض خذ نفس
بس ما تمش السيتنج بتاعها.
دع المانداتري ايش يصير فيها؟ يأجلها يحسبها قصدي يأجلها بعدين يعطيها.
اي لو if the patient starts before the preset rate finishes exhausted the machine will pause. Yeah, will not give him another breath.
وهي حاجة ضعيفة يعني بياخذوها بروحها.
لا حجي full before the sit. والله عودنا الكلام هذا 130 مرة عيد. If it's a preset rate the machine will give a full one. قاعد في 12 قاعد ما خلص الماشين did not finish the 12 breaths ما خلصوش قاعد في الخمسة فالماشين حتعطيه تام لكن بعد لو كملت المريض كملهم بدري تنفس بيبي يتنفس 20 هو وانت حاط له 10 بس باهي ال 30 الثانية الأولى خلصوا ال 10 اللي أعطيه ما زالوا 10 في باقي الدقيقة صح الماشين will not help him. إن شاء الله will not go back to this.
إن شاء الله.
Okay, so this is the picture of SINV. I just explained to you here. If there's no pressure support, that's a good point. If there's no pressure support, the machine المريض حاول تريجر وياخذ شوية هذا الفول لأنه هو تعبان لأنه هو على sedation لأنه his muscles are weak, right? And he trying to breathe, he hardly get any tidal volume there. هنا حطيت pressure support. أنا حطيت pressure support. You see? Still not matching the tidal volume he wants. So this is the difference. So this is the pressure support. If you look here, all triggered by the patient. هنا في pressure support المريض على الجهاز التنفس is connected to the ventilator. The ventilator would every time المريض عاوز يتنفس الجهاز يعرف لأنه هو he sucks air. It's negative pressure there. The machine goes, oh, he wants to breathe. Okay, you set up the rate. You set up, sorry, the pressure support. You say, I want to give him pressure support of 15, for example. Every time he breathes, the machine will give him air under a pressure of 15. He can breathe as many times as he wants. Right? He can breathe as deep as he wants. He can take 5 seconds just taking the inhalation, whatever he wants. Right? The machine will not stop that. You use PEEP with this one as well. We can use PEEP. It's not there, but you can use it. Any question about pressure support ventilation? We use it mostly in weaning rooms, right? We think our patient is, we'll talk about weaning later on. Our patient is weanable, then we have to check a few things. I'll show them to you. And he fits the bill, then we say, okay, let's put him on a pressure support. Why you put him on pressure support? You want him to use his own muscles and see if he's good enough to come off the ventilator, right? Because there's a lot of reason for someone to fail. Okay, so this is the pressure support. So which one we should choose, volume or pressure? I think we have the answer now.
according
Whatever you're happy with, whatever you're comfortable with, remember this. I'm just going to show some minor differences between both. If you're looking to ventilate someone, you want to guarantee someone with a CO2 of 100, and you want to guarantee, I want to wash out the CO2. The volume will guarantee the minute ventilation for you, right? Because you know how much volume you give, how much rate you give. I come back and the CO2 is still 100, that means I need to do more ventilation, I can go on the tidal volume, I can go on the, I'm in control, right? But if you use a pressure, you don't know if the patient is getting 300 or 500, it will be challenging for you, so it's a minor difference. Clear?
Yes, sir.
Yeah? This is one of the advantages. This is the pressure and volume. Tidal volume reduces more stable. And this is still advantage here. We're still talking about the advantage. There's something about the flow and the volume. We'll give a slow flow, which will help more with asthmatic patient, but I'm not sure about this. It's mentioned in some books, and you can use an ARDS in asthma. The problem with this, you have with the volume, the mean airway pressure is low, or it's not as good as pressure control. Remember, the mean airway pressure is peak inspiratory pressure and plateau and plateau. So you have no control over there. The other thing is you're not using pressure, so recruitment will not be as good as when you're using pressure. Is a pressure will force things to open, but volume can go somewhere else and will not open that lung, at the inflamed lung for you. Okay, let's skip that. What's the advantage of pressure control? When do we use pressure control? The most famous, common, serious indication if you have a leak. Okay, if you have leak means you have someone with bronchopulmonary fistula. You have someone coming out of the surgery with a chest tube dangling here, and the surgeons created a fistula for you. Or someone put a chest tube in the wrong place and went through the lung tissue and ended up with a fistula. Or someone had a large bully there, ruptures to the pleura, and every time he breathes, the air goes to the pleural cavity. So if you give him a volume, what will happen? All the volume will go there, and we get no oxygenation. But if you give him a pressure, the machine will not stop till the pressure goes to that preset target, like 20 or 25 or whatever it is, and with that we will guarantee volume to the patient, right? And the other indication they used more in case. children because they used uncuffed tube. They don't cuff the tube in children. But again, there's no major differences there. Okay. This title is how do I write ventilator orders in critically ill patients? So you intubated your patient and you want to write or put the orders, or in other parts of the world you put the orders and someone else will do called RT or respiratory therapist. Here you guys, you do it yourself. How you can set up the ventilator basically. First step is you want to choose the mode, right? And we said we agree about the mode, whatever you're comfortable with, okay? But always don't put someone in pressure support who's in the ICU, right? We don't do that because they're sick, they need help. That's why they're there. This is why you intubated them first place, right? So don't put them in the pressure support. You wean them on the pressure support, but initial one is controlled mode, which we said AC or PC. Why we do pressure controlled mode? Because we guarantee the breaths, right? We guarantee he will have X number of breaths, we guarantee the tidal volume, we guarantee the we are in control. That's the whole idea. Okay. Tidal volume or driving pressure. So if we use volume control, we decide about the tidal volume. If we use pressure control, we decide about driving pressure. So tidal volume we said 4 to 8, ideal body weight. How to calculate the ideal body weight?
Medical.
Height, male, female. You can Google those equations. Okay. And again, inspiratory pressure aiming for a plateau less than 13. So if your PIB is 15, your driving pressure should be less than 15, right? Peak flow rate, we said if it's volume, of course, you have to do it high because that will make your patient comfortable and will prevent asynchrony and will make your life easier. This is, with the new ventilator, is the flow profile is automatically will show up there. You don't have to worry. In the old days, you have to say, I want ascending, descending, sinusoidal, square, whatever, but now we don't do that. Inspiratory time, it's more with pressure control. You want an inspiratory time of point whatever of the second. Fraction of the oxygen, we went over it, right? From 60 or even 40 to 100, try to come down ASAP, look at the saturation and blah, 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 right? So come down as soon as you can. Mandatory breaths, we went over it again, 8 to 20 based on, or 18 based on the clinical scenario, what kind of problem I have there. And PEEP, and we discussed the PEEP yesterday, we call physiological PEEP, right? What's the physiological PEEP?
3 to 5.
3 to 5. Any other idea? I always ask this question when I put this lecture. There's no physiological PEEP. It's just something we are a physician, we say there's no such thing called physiological PEEP. In some big academic center, they put the PEEP 0. They don't do any PEEP. Because there's no evidence 0 or 3 or 5. And some other places say, okay, we'll do 3. Just everyone will be happy, so no one complains. But by default, we all do 5 of PEEP, right? Doesn't harm the patient. If it helps, good. If it does not help, it's okay. But again, nowadays we look at optimal PEEP. We have to put our patient in optimal PEEP. And we learned yesterday, if we have a problem with oxygenation, how we do our optimal PEEP. Everyone knows that. If you come out from this course by knowing how to set up your optimal PEEP, that would be perfect. And if you don't, ask me again. And the trigger sensitivity, we said it should always sit at around 2. If it's too low, we'll make it harder for your patient to trigger the ventilator, and we'll see a lot of asynchrony there, and the patient will be angry and upset from you. And what do you do as a physician? You give him more sedation, right? That's what we do. Right? Well, yeah. So, and if you give it too easier, if you make it more than 2, what will happen? If the patient coughs, it will trigger the ventilator. If the nurse move the patient, cleaning or doing something, it will trigger the ventilator. So the magic number is 2. All right, so this is just summary of what we went over, how to set the pressure or ventilator, or volume, and a little bit of advantage and disadvantage of, you can take a screenshot of this one if you want. It's just a summary of what we said. Okay. And this is a suggestion, I can do screenshot here too, of what you do or what kind of vent settings you do for your different scenario. For a normal lung, someone you intubate for airway protection, or someone with a COPD, someone with a neuromuscular disease, asthmatic ARDS, someone with congestive heart failure. And if you see it's mentioned here, mode, it's not specified. Whatever you're happy with, whatever you're comfortable with, use any mode you want, right? And this is the suggested tidal volume. But remember, these things are not written in stone, means you're as a clinician, you judge the patient. Well, oh, he needs more oxygen. He needs more than 50%. For example, a COPD, I'm going to give him 80 and come down. But just remember, your goal is to come down to 60 ASAP. For example, a neuromuscular disease, someone who cannot breathe but his lungs are good, his muscles are weak. Why give him 50? Why give him 100? Just give him a normal. He breathes normal air, so his lungs are healthy, right? So it's again, it's a clinical judgment more than anything else. I think this is the last slide. Now we go over the oxygen. Anything else here you want? You're done. Okay. Okay. So what do we do to improve the oxygenation? Just quick summary of what we said yesterday and today. We go up in the FiO2. My patient is hypoxic. His saturation is 85. Right? The nurse calls me. I go up in the FiO2 slowly. 60, 80, 100. So he's at 100% now. Still hypoxic. I try to increase the mean airway pressure. How we do that? By increasing the peak, we increase the time up, we can increase the tidal volume, we can increase the make inspiratory pause there, right? I did that, still hypoxic. I'll optimize the peak, like the way we did yesterday. Still hypoxic. I'll increase the inspiratory time, I'll do the reverse ratio. I'll just pause the inspiratory phase for some time in his lungs. This is another way of doing the inspiratory pause. Still hypoxic. I will prone them, and we went over the prone yesterday and how you do it and how you help. How does it help you? We don't do that anymore now. We don't do nitric oxide, and I'll call for help if you have the help. But I guess we didn't have ECMO in this part of the world, so your cutoff would be here. So you prone them. And that will be your, of course you have to manage the fluid as we said yesterday, so make sure they're paralyzed as well. So this is how you deal with hypoxic patient. Yeah, if you have a CO2 retention, you increase your rate, you can go up to 35. And the problem with increasing the rate, well, if you go up on the rate, what would be the negative side, downside? CO2 will go up, and you will trap more air, this time for exhalation, right? So you have to pay attention to that. Now CO2 will not build up here, CO2 will be washed out, but the problem will be the air trap. You can increase your tidal volume slowly, but always when you increase your tidal volume, think about which pressure. Plateau pressure, right? And the volume control. Every time you go up in your tidal volume, your plateau pressure will go up. So we have to keep a balance, right?
Increase respiratory rate. أزيد CO2 يعني؟
No. Okay. But remember, when you increase your tidal volume, will increase the risk of villi or volume-induced lung injury. We paralyze people. You can look at the carb, because high carb load in the diet will increase the CO2 protection, and you control any hypermetabolic state. Means if you have someone who has fever, tachycardic, severe septic shock, any hyperdynamic thyrotoxicosis, any hyperdynamic circulation will generate more CO2. Right? And if you've done all of the above and you have a problem, or you're still having a problem, you can settle for a pH of more than 7.2, what we call permissive hypercapnia. The body can handle anything with a pH more than 7.2. And that's why you see in chronic COPDs, right? They never have a normal pH. Right? Why we settled for 7.2? Anyone knows why? Okay. So, this is mostly related to the brain, right? Because the brain can handle up to 7.2. If you crash it more, you run into trouble. Any questions? So hopefully by now you know how to set up your ventilator, right? You know how to deal with hypoxic patient, hypercapnic patient. You have some idea about how to diagnose auto-peak, where your plateau or peak airway pressure should be, how you, what else we said? Okay, we'll have another short
Different modes.
test. Huh?
المودز.
And we know